Heart disease refers to a group of conditions that affects the structure and function of the heart and has many root causes. It is the second leading cause of death in Canada, claiming more than 48,000 lives every year. Atrial fibrillation is a condition involving an irregular heart rhythm with increasing prevalence in Canada. These types of disease are known as arrhythmia. This condition can cause the heart to beat very fast, ranging from 100 to 175 beats per minute, whereas a normal individual has a heart rate of 60 to 100 beats per minute. 33.5 million people around the world have atrial fibrillation. That's 0.5% of the world's population. Here in Canada, atrial fibrillation affects 350,000 Canadians, making it the most common type of arrhythmia.
There are three different forms of this condition, known as paroxysmal, persistent, and permanent atrial fibrillation. Paroxysmal atrial fibrillation is a temporary, sometimes recurrent condition. In this case, the symptoms may start suddenly but can return to a normal heart rate on its own, usually within 24 hours without medical assistance. Persistent atrial fibrillation lasts more than 7 days. The heart continues to beat irregularly and will require either medical or electrical intervention to return the heart to a normal rhythm. And finally, permanent atrial fibrillation is an irregular beating of the heart that lasts for more than a year when medications and other treatments have failed. Some people that live with this form do not feel any symptoms or require medications.
And it started quite suddenly. I was actually taking a shower and it started. I thought I was having a heart attack. I was told at the hospital at that point that it's atrial fib, AFib. Actually, some people can't feel it, but I feel that I know every single beat, and that's what makes it very uncomfortable. So I can feel my heart. I know which part is beating fast, which is irregular. So once it happens, I have to lie down. It is hard. I get lightheaded, dizziness, all that stuff.
Often the cause of atrial fibrillation is unknown, but causes can include high blood pressure, abnormal structure of the heart, infection or inflammation of the heart, diseases that damage the valves, hyperthyroidism, blood clots in the lung, congenital heart disease, and excessive use of alcohol. The risk of developing this condition increases with age, with the main complication of atrial fibrillation being stroke. 1/3 of all strokes after the age of 60 are caused by this condition. In addition, those with atrial fibrillation are at a 3 to 5 times greater risk for a stroke. Due to the rapid heartbeat, the condition can also lead to weakening of the heart, which may lead to heart failure.
The heart has its own self-conducting electrical system, which is generated spontaneously at the sinus node located in the right atrium. The impulse travels first through the atria, then through a connecting pathway between the upper and lower chambers of the heart called the atrioventricular node. As the signal passes from the sinus node through the atria, they contract, pumping blood from the atria into the ventricle below. As the signal passes through the AV node to the ventricle, it signals the ventricle to contract, pumping blood out to the body. In atrial fibrillation, the upper chamber of the heart experiences chaotic electrical signals. As a result, they quiver. The electrical connection between the atria and the ventricle is bombarded with impulses, trying to get through to the ventricle. The ventricle also beats rapidly, but not as rapidly as the atrium, as not all impulses get through. Atrial fibrillation is often associated with structural and electrical remodeling of the atria, which constitute the substrate of the arrhythmia. This atrial remodeling is characterized by short action potential, heterogeneous refractory periods, dystrophy myocyte, and interstitial fibrosis, which act together to favor local conduction block, activation of ectopic, and the formation of microentry of the electrical excitation. However, the underlying mechanism of atrial fibrillation substrate is not fully yet understood. To understand the theory of atrial fibrillation, it is required to understand the re-entry mechanism of arrhythmogenesis, which occurs when an impulse travels around an abnormal circuit repetitively. A landmark paper published in 1998 identified that the muscular sleeve of the pulmonary veins displayed electrical physiological properties, making them an implicated source of atrial reentry, triggering atrial beats in the presence of risk factors. Electrical remodeling can be a result of repeated inward calcium current that increases the myocyte calcium load. High intracellular calcium concentration can be toxic. Therefore, as an adaptive mechanism, calcium channels become less active and is downregulated. This reduces the inward calcium channel and in turn reduces the action potential duration, leading to shortened refractory period, and cell can be ready to reactivate again, promoting re-entry and perpetuation of atrial fibrillation. During structure remodeling, atrial myocardium undergoes some scarring, fibrosis, and changes in atrial size. This leads to an alteration in refractory period which causes atrial fibrillation. Pro-inflammatory cytokines and hormones related to cardiovascular disease and tissue injury promotes activation of leukocyte with subsequent release of cytokine and reactive oxygen species. Moreover, cardiac fibroblasts are activated and induced to proliferate and differentiate. As a result, connectin and ion channels dysfunction occurs, along with myocyte apoptosis as well as matrix regeneration and turnover, which leads to electrical and structural remodeling that predispose an individual to atrial fibrillation.
There's the Valsalva maneuver, which you breathe hard, but electrocardioversion is my preference to go back to normal. And as soon as, this is the interesting thing, as soon as I'm back to normal, I'm normal. It's like nothing ever happened. It's the best feeling. Right now it's the worst feeling in the world. And once your rhythm is normal, it is the best feeling in the world.
Treatment of atrial fibrillation depends on patient characteristics and their risk factors. If the patient, we are just looking to slow down the heart rate, we would use a beta blocker, a calcium channel blocker, or even digoxin. If the patient is not tolerating the fast heart rate and has repercussions on the hemodynamics, we would go with electrical cardioversion with a defibrillator and long-term treatment. If we have recurrence of the atrial fibrillation, it's not well tolerated, we could go all the way to ablation to control the atrial fibrillation at its source.
Catheter ablation is a surgical procedure that's completed on individuals that have an otherwise normal heart other than atrial fibrillation. The atrial fibrillation is going to be initiated by hot spots that contain abnormal pacemaker cells. With catheter ablation, a doctor is going to insert a long, thin tube, which is known as a catheter, into the groin and guides them through blood vessels to get to the heart. Electrodes that are at the catheter tips can use radiofrequency energy, extreme cold, or heat to destroy these hotspots, which allows for the scarring of this tissue so that the erratic signals are normalized. This allows for the correction of the condition without the need for medication or implantable devices.
Atrial fibrillation prevalence is expected to increase in the next coming years. An attempt to understand the underlying mechanism makes future research crucial.